I hope I am audible, and I hope the screen is also visible to you.
Yes, sir.
All right. So the topic for today is recent advances in cardiac imaging and the utility in diagnosis. And I don't plan to keep this as a lecture with a lot of study data and things like that. So it will be a little different from what you do usually. I'll be only showing some cases which will highlight recent advances as well as their utility in diagnosis. So essentially, when we say cardiac imaging, we are talking about many modalities. There's echocardiography, cardiac MRI, CT. There's nuclear cardiology. Then, of course, there's a whole world of coronary imaging and probably many more things. But broadly, this is what it is. But I'll restrict myself to echocardiography alone, with some touching here and there on the other modalities. So as I mentioned, it will be mainly cases. So I'll straight away start with the first case, who is a 23-year-old female. Again, these cases are not exotic cases, or they are very much day-to-day things that we see, but probably we need to have an eye for. That is what my intention is. So these are common things that we see, so nothing very rare or uncommon. So 23-year-old female who had a viral fever 1 month ago comes with one episode of dyspnea lasting very briefly at that time. And she was found to have an abnormal ECG. So that is the ECG. You can see that it is she's in sinus rhythm, and there is right atrial enlargement, and there are some ST changes noted. The chest X-ray, of course, shows pulmonary venous congestion, and maybe there's some straightening of the left heart border also. Her hemoglobin was normal, blood counts were normal. All investigations that you can see were normal, except for an elevated NT-proBNP, which was at 971 picograms per ml. This is her echo. Um, this is the parasternal long axis view. I'm sure many of you would have already come for your postings. But for those who are not familiar with echo images, on the left, I have a normal echo. On the right is this patient's echo. What we can see here is a dilated left atrium. This is the mitral valve. This is the left ventricle, which opens into the aorta through the aortic valve. And intervening between the two ventricles here, you have the interventricular septum. So here you have the right ventricular outflow tract, the interventricular septum, the left ventricle, the mitral valve supporting apparatus, and you have a dilated left atrium. So just note here that between these two images, what is obvious is that the left atrium is dilated here as compared to the normal person on the left side. I said this is the parasternal long axis view. I'm not really going to go into the depths of it, but in case you're wondering how you got this image, you have the model of the heart here, and we have kind of transected it in this particular blue axis. The perpendicular axis to that would be the short axis view, and the horizontal axis, somewhat similar to the axial CT cuts, or the horizontal axis, the transverse cut, would be your apical plane. Now, having said that, this is the apical four-chamber view, which is a transverse cut. And what you can see is the four chambers, the left ventricle here, the left atrium here, the right atrium here, right ventricle here. And you can see the mitral here and the tricuspid here. Intervening is the interventricular septum, the interatrial septum. Again, what is obvious, or what strikes us, is the fact that the left atrium is dilated. Why do I say that qualitatively? Because it appears to be almost as big as the left ventricle in size. So there are other ways to quantify that. But for now, as a preliminary impression, even in the two-chamber, it kind of looks 50-50. So that tells me that the left atrium is probably dilated. And we quantify that by by measuring the volumes, and that is how we have measured it in the 4-chamber and in the 2-chamber. And we get a biplane volume here of 70 milliliters. So anything more than 50 unindexed or non-indexed would be a dilated left atrium. And especially if we index it, then anything more than 34 ml per meter square would be definitely a dilated left atrium. So this patient has a dilated left atrium. I put the patient went on to have a cardiac MRI also because of this. This again is the 4-chamber. I have not been exhaustive in putting all the views and all, but something which is easy for us to understand. This is how the cine 4-chamber cardiac MRI image looks like. What I have done here is I've just rotated it to make it stand straight, similar to our echo image, so that we can understand what is happening. Now, we have a young lady who has come to us with dyspnea following probable short fever. And this is her cardiac MRI. Again, what strikes us is a dilated left atrium as compared to any of the other chambers of the heart. Also, at this point, I would like you to appreciate a few things. And that is important from understanding diastolic dysfunction. So why is this such an important problem? Because undifferentiated dyspnea is probably one of the most common symptoms that a patient comes to the hospital for in any outpatient clinic. So right now we are at a position of undifferentiated dyspnea. LA is dilated, cardiac biomarkers are elevated. We are thinking in terms of cardiac dyspnea so far. But I want you to appreciate that the whether it is systole or diastole, the long axis length of the heart doesn't change, which means the apex is in the same position, the base is in the same position. The heart is not, many times we kind of make a fist and we kind of show something like that. But that is not really how the heart contracts. That is good for just layman understanding. But what you can notice characteristically is the length of the heart doesn't change in systole and diastole. They remain fixed. So what is it that is causing the blood to be ejected from the heart? It is all that happens here in the middle, and that is what is responsible for diastolic function of the heart. So you can see how in the middle, that is in the atrioventricular region, the right ventricle moves up and down. Here in the mitral also, at the waist, here you can see how it is moving up and down. So essentially, in a nutshell, if we were to say the events that are happening here, in systole, the volume is becoming small. The left atrium fills. You can see this gush of blood coming in at the same time through the pulmonary veins. And then the mitral valve opens in diastole and the blood enters the left ventricle. So that is the summary of diastolic function. Anything that we see as abnormal in any of these things, we would call it diastolic dysfunction. So this is to put it graphically, what is happening here in systole. Systole is from the QRS till the end of the T wave, and the pulmonary vein flows. That is the PVS1 and PVS2 that you see here is this gush of blood coming in. And then after that, there is the mitral valve opens, and then there is the passive filling that happens of the ventricle. And finally, the left atrium contracts, and the last bit of blood is pushed into the ventricle during that time. I told you that it is not like it's not like clenching of a fist that the heart contracts. So what is new? That the heart always contracted like this is not new, but our understanding and the ability to demonstrate it using echo is new. What do I mean by that? Till now, we were quantifying ventricular function using traditional methods of ejection fraction. That was the dominant way in which we kind of expressed the function of the heart. However, this knowledge of how the heart fibers are oriented, that's a historical picture which tells us that the heart muscle can be unwrapped like a sheet. It's a sheet of fiber, and that has been kind of wrapped around in a certain fashion, and that is what gives the ringing motion of the heart. So you can remember a wet towel, and what is the most energy efficient way of pumping that water out of that wet towel? It is not by pressing, it is not by compressing, it is not by making that fist kind of motion, but it is by wringing it, which means you are moving a certain part of the towel in one direction, and the opposite side of the towel moves in another direction. And that is the most energy efficient way of generating power. So, the heart muscle fibers are arranged such that the endocardial fibers are arranged in a linear fashion, in a longitudinal fashion like this. The mid-wall fibers are arranged in a transverse fashion like this. And in the epicardial fibers are arranged in an oblique way like this. So what's the big deal about this, and why are we kind of going on about this? We have ways now to demonstrate these respective different fiber motion. So when we say longitudinal strain, we are essentially predominantly talking about this longitudinal motion, how the length of the fiber shortens in the long axis. If we say radial strain, we are talking about how the wall is thickening and the wall is moving towards the center of the heart. And when we say circumferential, we are talking about how the fibers shorten in this particular direction. So what is the implication? To give a very simple example, ischemia, as we know, affects predominantly the endocardium. The wavefront um, uh, goes from endocardium towards epicardium, which means uh, the tissue most affected by cardiac ischemia is the endocardium, and then it goes outwards. Whereas you have a disease like constrictive pericarditis, it is the pericardium which is involved, and hence what will be affected the most would be the epicardial fibers. So we are able to distinguish various types of myocardial diseases and pericardial diseases in echocardiography, not only just by looking at the 2D morphology, but also using these additional methods. So what do I mean by that? In a condition like ischemic heart disease, I would find that the global longitudinal strain is reduced. And however, the others may not be affected much, depending on what is the severity of ischemia. Whereas constrictive pericarditis, I may find that the global circumferential strain is reduced, but the longitudinal strain is not only preserved, but it may be exaggerated also as a compensatory mechanism. So this is what I was telling you about, and it can be depicted by various waveforms. Suffices to say that the heart, the left ventricle rotates in an counterclockwise at the apex and in the clockwise direction at the base. So that twisting motion is what gives the cardiac output. Now, coming back to our patient and the diastolic function, you must have seen in echo reports, and you must be aware of the E wave and the A wave. You can see the ECG here at the bottom, which means the QRS to the end of the T wave is systole. When we say diastolic dysfunction, we are interested in this part of the trace, that is the E wave and the A wave. The E is the early filling, like I said, or if I can go slow here, so that is when it is maximally open, the mitral valve, that is the E wave. And you can see that as I go further, the valve tends to close, but then again, just after the P wave, the valve opens again. So again, just to show that, I'll play that, and you can see the events mechanically also. So I'm just tracing it. Now it's open, that is the E wave. And then after that, it closes a bit, that is diastasis. And then it opens a little more, that is towards the end of diastole when the atrium contracts there. That is the A wave. So that is what has been expressed here. So now there are different parameters that we know. I'm not really going to go into the depths of that. There's E by A ratio and all that. But I just want us to understand the principle rather than the numbers and the different parameters. So what is this E wave telling us? The E wave tells us that there is a pressure difference between the left atrium and the left ventricle. Now the pressure difference is what is depicted here. The pressure difference may be related to multiple factors. So hence just looking at this one picture or these values alone will not tell us everything about diastolic function. So when I say there's a pressure difference, that means either the left atrial pressure is very high in relation to the left ventricular diastolic pressure at that point, in which case it tells us accurately that it is a true reflection of diastolic dysfunction or an elevation in left atrial pressure. But it is also possible that the left ventricular diastolic pressure may be very low, generating the same amount of pressure difference and a pattern looking exactly like this. In which case, then this trace will not tell us about diastolic dysfunction correctly, or it will just looking at this alone doesn't tell us everything about diastolic function. So what do I mean by that? In a very healthy person, in an athletic person who is generating a very negative suction or has a very healthy left ventricle, the blood is getting pulled from the left atrium. It will almost be like a negative pressure. So hence there will be a good gradient and that will be reflected in exactly the same way. So hence we need additional parameters for quantification. This is exactly what I'm trying to say. So the left ventricular systolic and diastolic function here seems to be very good. The annulus is nicely pulling it and all the blood from the pulmonary veins is getting sucked into the left atrium and from there into the left ventricle. So that means the ventricular relaxation, that this up and down motion is also quite good. That is what we depict by this E prime velocity. So this up and down motion that I'm talking about is a measure of the tissue velocity. That is what we try to measure here. So when we say E prime medial and E prime lateral, it is at the medial and lateral part of the mitral annulus. And how much it moves tells us how good the annular function is. So if it is moving well, that means that the blood from the left atrium is getting pulled towards the left atrium nicely, towards the left ventricle nicely, and the diastolic function is likely to be good. So here, the velocity, as you can see, is close to 10 centimeters per second, 11 centimeters per second. All this is normal. We have a ratio called the E by E prime ratio. And as I told you, the E velocity we got from the mitral inflow, which tells us about the pressure difference between the left atrium and the left ventricle. And this ratio corrects for the myocardial function. And this truly then tells us what the left atrial pressure is. So the mitral inflow velocity is dependent on load, as I just told you, on preload, whereas this is a relatively less preload dependent parameter. So a ratio of the two will give us a good reflection of what the actual left atrial pressure is. So if the E over E prime is high, that means your left atrial pressure is high. So that is essentially what diastolic dysfunction is. So you here on top, you have the different grades of diastolic dysfunction, grade 1, 2, 3, and normal. And here at the bottom, you have the tissue velocities. As you advance in grade, you can find that the E velocity increases and the E prime velocity reduces, such that in grade 2 and 3, diastolic dysfunction, the left atrial pressure is high. So what is the implication of this? Somebody coming to us with undifferentiated dyspnea, you find a dilated left atrium, you find low tissue velocities, and you find a high E over A ratio and a high E over E prime. That patient has an advanced grade of diastolic dysfunction. You are likely to find increased NT-proBNP, and that patient is most likely has heart failure. Versus another patient who comes with, again, undifferentiated dyspnea, but has a pattern looking like this at rest, and the patient says, I'm breathless at rest, that patient is unlikely to have cardiac failure as compared to this particular patient. Now, if that patient were to say only when I walk, I get breathless, that is still possible that it could be heart failure, in which case we need to make the patient walk or exercise and then see what the pattern becomes like. But a breathless patient at rest demonstrating a pattern like this, it's very unlikely to be cardiac. So that is how this principle helps us. And so I assume that you've had your lecture or your class on cardiac failure and pulmonary hypertension, which is why I chose to start with this. And you have these three things, which is the crux of diastolic dysfunction and heart failure. So you have impaired relaxation, which is an energy dependent process. That is the initial part of the relaxation. And then as the disease progresses, the compliance also reduces. What do we mean by that? The myocardium becomes stiff because there is stuff getting deposited in between the myocytes. There is fibrosis, and that changes the myocardial architecture to a very stiff kind of thing, left ventricle, which doesn't relax much. And the consequence of that is an elevated left atrial filling pressure and the patient being breathless. So that is how it goes. Now, coming back to our case, I told you this longitudinal function is what we are looking at. Now, what is this longitudinal function and what is this GLS as we call it? So to understand it very simply, suppose the initial length of myocardial fiber is 10 centimeters. And then in systole, you can see this is systole, the QRS to the T wave, and how the fiber shortens. So this curve is essentially different parts of the LV showing the multiple colors, and it is kind of shortening. So it is supposed to shorten at peak systole. And and you can see that if the initial length was 10 centimeters and it became 8 centimeters, we say that it has shortened by 20%. And we would, the way we would express it would be minus 20%. So essentially, that is what is happening here. In each of these segments, the myocardial fiber is shortening, and that is what we express as a percentage. And for the entire LV, when we take it using multiple views, we call it global longitudinal strain. So that is what has been depicted here in this particular picture here on the right side. So these are all the outer circumference shows the basal segments. These are the mid segments, and these are the apical segments. So these are the basal segments of the LV, these are the mid segments of the LV, and these are the apical segments. That depicted in this manner gives us global longitudinal strain. And this again temporarily tells us that all the strain, the maximum strain, or all this red is happening at the same time. So now if that shortening, the value can be normal, but if it was happening at different times, that is what we would call as dyssynchrony. So which means this part contracts differently from this part, and that is what we call as dyssynchrony. Expressed in this, it becomes easier to see. I told you about volumes. Now, traditionally, the left atrial function also used to be assessed, just like how we assess ejection fraction for the left ventricle, which is difference of the maximum and the minimum volume expressed as a percentage. Similarly, we used to do that for the left atrium. Now, the left atrium has many more phases, and hence it can be quite cumbersome trying to study left atrial function this way. So the global function of the left atrium can be the maximum and the minimum expressed as a percentage. So this is how the pressure volume curve for the left atrium looks like. Don't get baffled by this. So what is happening here is that during the reservoir phase, the left atrial volume is increasing up to a peak. The mitral valve opens, and then the conduit function, that is the E wave, happens. And then the A wave when the left atrium contracts till the mitral valve closure. So that is how you have an atrial loop and a ventricular loop. Need not go into the details of this. Suffices to say that is how the left atrium pressure volume curve looks like and the different phases. Now that is what we now just first look with the naked eye how this whole thing looks. You can see how nicely the right atrium, right ventricle is going up and down, contracting very well. Left ventricle we already established has normal systolic function and seems to be having good relaxation properties also, as we demonstrated by the E prime velocity that we just showed in the tissue Doppler. The right atrium also with the naked eye see how it kind of expands and becomes small. However, the left atrium appears relatively sluggish even with the naked eye. Now, that is what we try to study better using either a volumetric method or a simpler method, which is a new advance, if we can say, the left atrial strain. Sorry, that should be left atrial strain. This is a normal trace here. So during the reservoir phase, the left atrium fills. Then after that, the E velocity happens. That is the early phase where the mitral valve opens. And then finally, the atrium contracts. After the P wave, there is the booster pump function of the left atrium. So these are these three numbers which will be shown in any echo report. Where the left atrial strain is done. Reservoir strain being represented as a positive number, and the conduit strain is a negative number because at that time the left atrium is emptying, and the contractile strain, again, the left atrium is emptying at that time. So anything more than 24% is normal. So this is a normal trace. Now, look at this trace, which is our patient that we are talking about. And the left atrial reservoir strain is markedly reduced. The contractile strain is also reduced, conduit strain. All phases of the left atrial function are markedly reduced. And this generally correlates with fibrosis on cardiac MRI also. This patient also has a pulmonary hypertension. Last time you had a lecture on pulmonary hypertension. So how do we assess pulmonary hypertension? I'm sure you know by now. PA systolic pressure is right ventricular systolic pressure plus the right atrial pressure. So we take TR, sorry, this again is not the right ventricular systolic pressure. This should be the TR gradient plus the right atrial pressure. TR gradient is what we have shown here on the right side. TR gradient is the pressure difference between the right atrium and the right ventricle. So to that, we need to add the right atrial pressure, which we can get by looking at the IVC. Now, there are different ways to look at the IVC and assign certain values of pressure to the right atrial pressure. And the sum of this and this gives us PA systolic pressure in the absence of any significant pulmonary stenosis. Otherwise, PA systolic pressure is actually equal to the right ventricular systolic pressure. So the value here is more than 30, 36. So straight away, the patient has pulmonary hypertension. PA acceleration time tells us the pulmonary vascular resistance. This is quite helpful when we need to differentiate whether it is just a transmitted pressure from the left atrium that we are capturing as an elevated PA pressure, or there is pulmonary increase in pulmonary vascular resistance. So suffices to say again that anything more than 100 is normal. So in our patient, it just seems to be transmitted pressure, not related to any pulmonary vasculopathy yet. So this was the chart you might have looked at. 75% is due to left heart disease. Valvular disease and all is easy to figure out. Systolic dysfunction also not a big deal. Diastolic dysfunction may be a little tougher. But what I have shown you encompasses everything, which is that we have a situation here where systolic function is normal, diastolic function is normal, valvular, there's no valvular heart disease, no congenital, nothing is there, only a dilated left atrium. And that left atrium is not only dilated, it is also dysfunctional. And that is the reason why this particular patient has an elevated biomarkers and also is symptomatic. The patient's cardiac output is not compromised. This is the LVOT-VTI. You would have, I'm not going to go into the details of this, but whatever it is, this patient's cardiac output is good, and that is not compromised as a result of this left atrial dysfunction. The purpose of showing this is that I want you to kind of note how this tracing has been done. What is new in echo? This is also what is new in echo. Earlier, we would have to kind of manually trace all these contours. But now we have echo with AI, which means the machines that we have here in CMC today and in the world have automatic contouring, which means we just acquire that particular contour trace. The border detection using different algorithms happens in the computer of the echo machine, and we get a trace that I just showed. We also are moving towards automatically sorting images, coming to pattern recognition like diastolic dysfunction, constriction, using echocardiography, not manually like how I or you would do it. And then finally integrating that with clinical data of ECG symptoms, etc., and coming to disease diagnosis. So this is what I showed. This has been done using AI, which is there in the echo machine. This contouring is automatically done. This is not manually traced. So what is manually done is just a good four-chamber view and the click of a button, and this happens automatically. Similarly, our traditional measures also, we just take the echo image, all how much is the wall thickness, all that. It is not in there in all our machines, but some of our machines, even in our echo lab, have these features. I told about image sorting. So here, if you pay attention, here again, we have taken strain images. Now, these strain images have been sorted out using automatic sorting, which means I just need to click on that GLS button, and it will know which images to pick from the ones that I have acquired and give us the global longitudinal strain. Pattern recognition is like what I just told you. There are many algorithms that we use. If this plus this is there, then it is constriction. If only this and this is there, then it is restriction. Or if this plus this is there, it is diastolic dysfunction grade 1 or 2, like I just showed you. Now that also, there are different softwares which are available now, and which will give an automatic interpretation provided you have good images using these pre-existing guideline-based algorithms. So that is just a kind of picture or a image to show from image selection to automatic segmentation to automatic function assessment to cardiac diagnosis. And this is exactly what I've said. The expanded indications are going on, and amyloidosis is a very interesting disease which has typical findings, and many of the things we may be able to automatically detect not very far from now. So integrating history and physical nodes to echocardiography with image automation, combining that with blood tests, and then you can, we'll have AI in the future to integrate all of this and give us meaningful data. So our patient that we are talking about, the cardiac MRI parameters were essentially all normal volumes, cardiac output, everything was normal, coherent and consistent with what we saw on the echo as well. The LA, of course, the wall being thin, could not be properly characterized. So we have, does our patient have diastolic dysfunction? So these are the 4 parameters that we need. So we find that the TR velocity is high, LA volume is increased, but what we find is that the tissue velocities, all this is normal. 2 parameters normal, 2 parameters abnormal. It is typically an indeterminate diastolic function. We cannot leave it like that, and the patient is symptomatic with elevated BNP. So we finally conclude that our patient has left atrial disease. It could be a left atrial cardiomyopathy, which may be a sequelae of the viral myocarditis, or it could be a genetic cardiomyopathy as well. So that is how we have reached this particular, a little bit about the cardiomyopathy itself. This is the left atrial cell, and we have ion channels, and there are structural proteins like titin inside, and there are other binders between cells which are called gap junctions. So generally what we find is if it is ion channels, they can impair function without impairing structure much. Whereas if it is structural proteins, it will tend to have an impact on both. That is like in a nutshell. How is all this information useful for patient treatment? So when we approach a case of undifferentiated dyspnea like this, and we have gone on in a systematic way to assess whether there is diastolic dysfunction. If not, is there a left atrial dysfunction to explain the pulmonary hypertension and the symptoms? We arrive at, in real life, at something like this. We will find patients who have marked LV dysfunction, but their left atrial function is quite well preserved, and they tend to be not so symptomatic. On the other hand, we'll have patients like our patient who will have well-preserved left ventricular function, but a predominant problem may be a left atrial problem. And that can explain why they are symptomatic and why their biomarkers are high and why they have pulmonary hypertension. A vast majority of patients will lie in the middle, like any other disease. This brings us to this entity, which is a fairly new entity called disproportionate left atrial cardiomyopathy, which we may see in patients with traditional risk factors who we call as HFpEF. They may be patients who will have varying degrees of left ventricular and left atrial function, and that may explain why some are symptomatic and others are not. So this is not just left atrial dilatation or some abnormality and on the ECG. It is a composite of mechanical function, of electrical dysfunction, and also atrial fibrosis. I will skip this part. There are different mechanisms to explain this, but I'll quickly go on. I put this up. This patient actually has cardiac amyloidosis. The patient is in sinus rhythm. And what you can see is that this patient also has left atrial dysfunction, as the reservoir strain is only 5%. That is like marked left atrial dysfunction, even though the patient is in sinus rhythm. So the implication of this is that patients when in sinus rhythm also can have left atrial dysfunction. And this is a paper which kind of tells us that it is not atrial fibrillation leading to thrombus, which leads to stroke and dementia. It could be the other way around, that patients with left atrial dysfunction may be more predisposed to atrial fibrillation, and that could be the reason why they manifest clinically. So it is changing our understanding of disease, and possibly in future also could be how we may take therapeutic decisions on anticoagulation and all that based on this knowledge. So the learning points from this is left atrial structure and function are likely to become part of a routine evaluation of dyspnea in future, and it already is. It may be reduced ahead of major structural changes like dilatation. And we should be aware of this entity called disproportionate atrial cardiomyopathy, which we may see in many of our patients with traditional risk factors, diabetes, hypertension, elderly, etc. I'll very quickly go through another case, and then I will stop. This is a 39-year-old female with exertional dyspnea for 1 week. I take this liberty to go on for another 10-15 minutes because we started late. I hope that is okay with you. Is that okay with you, or shall I stop?
It's okay, sir. Continue, sir.
Yeah. All right. So very quickly, 39-year-old female with exertional dyspnea for 1 week. Again, a similar history of some fever 1 week prior. No comorbidities at all. Now, this patient has very scary, bizarre ECG. Multiple VPCs, there is IVCD, there is AV dissociation in the ECG. That is, the date is kind of mentioned. On admission, markedly elevated cardiac enzymes. Otherwise, everything is okay. Whatever is abnormal, I've highlighted in orange. So again, I'm not going to go into this, but for us to be aware that infarction is different from injury, something to bear in mind. Not all elevation is because of infarction. Rightfully so, we would like to rule out coronary artery disease. That's the right coronary artery, looks pristine. Left coronary artery branching into the left circumflex and the LAD, they also look very good. No problems there. The next day, the rate has begun to settle, and still the IVCD persists. There is, it's now a junctional rhythm. An echo is done. What you can see here is that the left ventricle is not functioning very well. There is mild LV dysfunction on visual kind of assessment. Also, what we can see is that this part of the septum, the interventricular septum, is not contracting as well as the opposite side. So that is, there seems to be some kind of wall motion abnormality. So what we have is a young lady again with dyspnea, elevated biomarkers, and ECG changes, including junctional rhythm, IVCD, and normal coronaries. So this I already told you, that is the long axis, and the short axis would be perpendicular to that. So this is the view perpendicular to the previous view. And again, ventricular function visually appears to be mildly reduced. This again, the interventricular septum, you can find that this part is contracting a little less than the rest. This is the three-chamber view. Again, you can see the interventricular septum here contracting a little less as compared to the other segments. Again, there was no pulmonary hypertension. I'll skip all this. RV function was normal. I just would like to show this particular image since we talked about strain. And you can see that this is the red. This has been coded as red. That is the basal interventricular septum. And the contraction here is in the opposite side as compared to, which means during systole, it is lengthening. That is a paradoxical motion. Likewise, here, the basal septum, inferior septum, which is coded in yellow, is also not contracting very well. So in short, what we have is this lady with a wall motion abnormality with some septal abnormalities. However, the angiogram is normal. And that is exactly what we found on the bullseye plot, that this is the anterior septum, this is the inferior septum, and the anterior septum seems to be a little more involved than the inferior septum. The other segments seem to be reasonably all right. Left atrial function is also reduced. That's not playing in this particular patient. The QRS duration, I'm not sure whether you noticed, but it's been steadily coming down. Things seem to be settling down. This is the STIR image, the short tau inversion recovery, which is a T2 weighted imaging sequence. And what I would like you to appreciate is this interventricular septum, how bright it is, and that signifies edema. And likewise, we have this late gadolinium enhancement in the short axis view. This is the left ventricle. This is the right ventricle, the interventricular septum, in exactly the region where our strain values were low and what we thought was not contracting very well. You see this subepicardial enhancement going and becoming mid myocardial. This is what we call as a ring-like enhancement. So till now, we would have thought that this is myocarditis because our enzymes are elevated, ECG changes are there, coronaries are normal. and MRI also shows edema. So it is phenotypically, if I can call it, it is myocarditis. But based on different patterns of enhancement, we can classify or we can differentiate ischemic from non-ischemic. Again, I'm not, for the lack of time, I'm not going to go into the depths of it. Enough to know that we can differentiate disease based on this. And our radiologists would definitely be more experienced with this, but this is for our information on how we come to a diagnosis of myocarditis based on certain parameters. The name of the criteria is the updated Lake Louis criteria 2018. And various disease conditions can be differentiated using the ECV T2, T1, myocarditis from Fabry's, from iron overload, from amyloid. So these are typical pictures which you will see in any MRI presentation. So putting it all together, that is what it is. That is where, so far so good. This wasn't really the new thing that I was wanting to say. All the viral markers were also negative. Connective tissue workup was negative. Patients' QRS is coming down slowly. PET was mildly positive. Apologies, it's not playing. Finally, the patient comes to sinus rhythm and enzymes are also normal. Now, I want us to be aware of this entity, which has been defined in the last 1 year or so, which is called a non-dilated left ventricular cardiomyopathy, where the LV is not dilated. The definition is there is a non-ischemic LV scarring or fatty replacement in the absence of LV dilatation with or without global or regional wall motion abnormalities, or it is just LV dysfunction without any of the other things. Just global LVEF less than 50% would fit into this entity. Now, why is this so important? So before I come to that, whenever we get a cardiomyopathy, the first thing we need to go through these 5 steps. What is the clinical scenario? What is the morphology? And when I say morphology, it is whether LA is dilated, LV is dilated, all of that, whether there's a scar, etc. Then putting it together, what is the phenotype? We should be able to classify it into one of these 5. The newest kid on the block is the non-dilated left ventricular cardiomyopathy, and then any additional things like lymph nodes or things like that, or a family history, and then we integrate it all together. So in our patient, so what is new? This is what is new. Now, the clinical picture is like MI with non-obstructive coronaries or a myocarditis with an abnormal ECG. Morphologically, normal cardiac chambers, mild LV dysfunction, reduced GLS, there is LA dysfunction also. And we find this ring-like enhancement. Note that term, ring-like enhancement, and myocardial edema. The phenotype, what is it? Is it dilated? No, it is a non-dilated LV cardiomyopathy. Additionally, what did we find? Arrhythmias, conduction system disease, elevated drops, BNP. So now we need to put it all together and narrow it down to the diagnosis. Now, this is what is new, coming up more and more. There are different genes that are responsible for this ring-like enhancement. Desmoplakin genes, LMNA or Lamin genes can present with the different kinds of the Duchenne's, for example, has a typical pattern of enhancement. Myocarditis has a typical enhancement, which is more towards the infralateral region, unlike our patient. There are different ECG changes. Based on what ECG change, we can probably come to a conclusion as to what genetic cardiomyopathy it can be in the non-dilated LV cardiomyopathy. Again, based on the pattern, ring-like enhancement, we can narrow it down to certain differentials. If it is in the septum mid-wall, it is laminopathy, whereas if it is more ring-like, it is desmosomopathy. And some other variants. So this is, again, this is not to confuse you. This can be a difficult entity. That is the reason why I put this up. As you can see, just the presence of global hypokinesia is what kind of presence that this patient may present with, especially in the absence of arrhythmia or ECG abnormalities, can be a tough thing to diagnose. Now, what's the big deal? Why do we need to know all this? That is because it has a fairly high rate of sudden cardiac death. So what is new? The genetic markers are entering the decision-making algorithm for ICDs. Unlike earlier, where it was only based on EF, now you can have an EF of 45%. But if you have gene positivity with some of these imaging markers, that becomes an indication for an ICD. So cardiac arrest, of course, you need an ICD. EF less than 35%, of course, you need an ICD. But if not, then you look at high-risk genes and you look at additional factors like this LG that I just showed you. Certain patterns of that can be more arrhythmogenic as compared to others. So this is all from the guidelines. It's already there in the guideline document which came out last year for cardiomyopathies. I want us to only pay attention to this part where the genotype has also entered the decision-making process. Further interest, you can read this particular document and become more aware of this. Ring-like enhancement, much has been talked about this year to differentiate different types of cardiomyopathies, and most of them turn out to have a genetic basis. Prognostic value, so the basis for why it is there in the guideline. So regardless of the EF, or regardless of the scar burden also, the pattern of enhancement is also important. So from EF, we move to LG, and how much of LG is there? What is the scar burden? From there, we are moving to patterns of enhancement, and that kind of signifying risk. Those with ring-like enhancement have the highest risk of mortality. I will stop with this particular terminology, which is we need to be. So it is not only clinical medicine. We have moved from there to imaging, echo, and from there to LG, and from there to genetics, combining that the phenotype and the genotype. And we have imagenetics for more precision medicine. And dilated cardiomyopathy or cardiomyopathies are something that we see left, right, and center every day. So keeping an eye open for could it be a genetic process that I'm dealing with could be very important. So I think in the interest of time, I had other things also, but I will stop here. If there are questions, I'll be happy to take. So in summary, I showed you two cases. One, a patient, both patients with heart failure. But in the first case, I talked about strain. What is new in strain? The left atrial strain that helps us to classify patients of undifferentiated dyspnea and pulmonary group 2 pulmonary hypertension better. The second case I showed mainly to highlight imaging and genetics and being able to phenotype and genotype these patients a little better. Thank you.
Thank you, sir, for the nice presentation. Sir, I wanted to ask, like, in this patient with the acute setting, like how the pulmonary hypertension develop, and is it reversible? Like, is it curable completely?
Yeah. So that is mostly related to left heart disease. It's basically because of, so we need to look at it not only at the level of the left ventricle. Group 2, if we say we start with the left ventricle, then we move up and say, is it the mitral valve? Then we move up and say, is it the left atrium that is the problem? If none of these, then we move to the pulmonary veins. Is the pulmonary venous stenosis or obstruction the problem? And so on and so forth, all the way up to the pulmonary capillaries. The problem can lie anywhere along this route, depending on what disease we are dealing with. And in this particular case, it seems to be related to a dysfunctional left atrium. And regarding your second part about reversibility, there are trials which are ongoing. Whether our usual heart failure medication will whether there's a role for ACE inhibitors or the 5 pillars, whether any of those drugs have mortality or symptom benefit. Those are all matters of ongoing research. However, anecdotally and otherwise, most people would start these patients on usual heart failure therapy in the absence of definitive evidence.
Thank you, sir.
Anything else? If not, any other questions? There's a lot more. There's 3D, there is intracardiac echo. In echo itself, there is strain echo, stress echo, so many things. Whoever is there is free to come and see all of these things. I confine myself only to things that we are doing here in CMC, many of the newer things also. There are many things I could not cover in this short time, but you are free to come and observe and during your echo postings. All right, shall we stop?
Okay, sir. Okay. Yes, sir.
Thank you.
Thank you, sir. Thank you.